Good evening, students. Welcome to Seminar in Oral Rehabilitation. This is June the 4th. We are working with our textbook, Foundations of Oral Rehabilitation by Nancy Ty Murray, the 3rd edition, and tonight we're going to be considering Chapter 3 on speech recognition for persons who have hearing loss and hearing aids, cochlear implants, assistive technologies of various kinds, and our role as SLPs in troubleshooting those devices. So please do remember to download the PowerPoints, or at least open them on your devices so you can follow along, and make sure that you have the handout materials developed or where you can access them. I have turned on the archive, so those of you who are on your mobile devices, I can certainly see on my screen that several of you are on your mobile devices and some of you are on teleconference. So if you need, after tonight, to be able to access this material, you can download the MP4 from the archive section of eLearn, where you can see the slides perhaps better than you might be able to do on your mobile device. And you can listen to the audio. Before we get started tonight, let me do just a little review and housekeeping while several folks are still joining us from their practicum setting. I want to thank everyone for submitting their Chapter 2 and Chapter 3 questions or for emailing me with further information about any problem you had. Again, the reason I ask you to complete these self-assessment end of the chapter questions before coming to class is that that's a way for me to assure and you to assure that you've at least looked at this material, so our discussions in class are more productive, that we can move on to consider additional materials that ASHA has provided us, materials that we might need in our practicum sites. I also want to tell you I very much enjoyed your discussion post. It seems that most people in this class were interested in children, all the way from infants and toddlers. I presume you're thinking you're going to open a private practice and serve that very youngest population in your private practice. Others were interested in school-age children, all the way from preschoolers and elementary school children to middle schoolers and high school students. But a number of you did indicate that you are particularly interested in adults. And I want to encourage you that if you have adults in your medical setting, that you want to go to the eLearn content section and you want to look at the entire module on adults, where in addition to reviewing the material in your textbook, Part 3, Oral Rehabilitation for Adults, beginning on page 383 in your textbook, I have posted a number of resource materials in the content section from ASHA that I think may be helpful to you. So Jill, Ashley, Sarah, Nicole, there probably were others. I just remember that in your post you indicated an interest in adults. But there are some ASHA resources in that module on adults that we will get to and talk about, but maybe not soon enough for you to have them right now when you need them. You may want to particularly look at Ann Olson's material on working with adults with cochlear implants. You may want to look at Linda Thibodeau's material on intensive AR for adults. You might also be interested in looking at Jill Preminger's AR for adult partners of individuals with hearing loss. And you may also want to be looking at the resource material that I put up from the ASHA leader on apps and HATs, hearing assistive technology for older adults. Now, there are lots of other things. Those of you who may be dealing with adults with dual sensory impairments, meaning that they have vision problems as well as hearing problems, I put up an ASHA short course on working with those individuals with dual sensory impairments. That material does a really nice job, I think, of reviewing what are normal age-related changes in hearing that we should expect and normal age-related changes in vision and how those two interact. And then what are disorders of hearing, which obviously we're interested in, but also the disorders of vision, diabetic neuropathy, macular degeneration, glaucoma, cataract, and how those types of additional medical problems complicate the process of speech recognition for our seniors. So again, I don't want to leave those of you who are particularly interested in adults thinking, well, will she ever get to what I want to talk about? The place to go is to the third section of your textbook and the module in eLearn content about adults. Those of you who are particularly interested in children also want to look at Part 4 in your textbook. Chapter 14 talks about infants and toddlers, and then Chapter 15, which we sort of highlighted a little bit last week, really addresses school-age children with hearing loss. Now, in the next week, we're going to move on through Part 2 in your textbook. And next week we'll be talking about auditory training, and we'll be talking about speech reading and speech reading training, chapters 4, 5, and 6. And those chapters have a lot of material, practical therapy material. How do you do therapy with both children and adults? So we are going to hopefully get to some fairly practical treatment options for individuals with hearing loss. Let me stop for just a minute and ask, are there any questions that came up either from the assignments or from the content from last week? Is there anything that we need to review or consider? I'm happy to answer any questions that anybody has or review any material that we need to take a look at. Okay, don't hesitate to stop and ask as we move along. If you have a question. I do want to make sure I remind you that next week, Tuesday, June the 20th, you will have chapter questions again, and this time they will be chapter questions on Chapter 4 on auditory training and Chapters 5 and 6 on speech reading. I actually am not sure why Nancy Ty Murray divided speech reading into 2 chapters. And in fact, in an earlier edition of this text and in the 4th edition of this text, she actually puts it all into 1 chapter. So even though it looks like a lot, it actually is, speech reading really is chapters 5 and 6, but they really go together. So we're going to be talking about therapy, treatment approaches, both the assessment part of that area and the intervention part of that area in terms of auditory training and speech reading next week. So you do have chapter questions. You also have a chapter discussion question, the 2nd discussion question. I moved the time, the due date. It is due on Tuesday the 20th at midnight. So that'll give you, those of you who kind of open up eLearn and start thinking about this course on Tuesday night, you have until midnight to submit your 2nd discussion question. Your 2nd discussion question asks you to think about the client that you are choosing for your case study in this course, and to look at the audiogram for that client that you have decided you're going to do your case study on, and to put your client's audiogram onto the familiar sounds audiogram, if it's a child, or the count the dots audiogram, if it's an adult. And then to think about what kind of speech recognition skills your particular case study client has, given the degree of hearing loss, the configuration of their hearing loss, and then what speech sounds are going to be particularly difficult for that client. What parts of the overall speech signal is that client going to miss because they are not accessible? Now, we're going to be talking about that all tonight, but I want to remind you that you do need to be accessing the audiogram for your client. This is actually the first part of your assignment to write a case study on a client. So this is a discussion that you're doing. It's a little piece of preparation for writing your case study. So you're going to, again, determine which of those tools seem best to you, given your client, to one, maybe explain to yourself, what does this hearing loss that my client presents with, based on the audiogram, tell me about what they can perceive of the speech signal? We're also going to talk about using these 2 templates, the familiar sounds audiogram for children and the count the dots audiogram for adults, as a counseling tool for you as an SLP to be able to explain to your client and their family members, be that a parent of an infant or toddler or a school-age child, a teacher of a school-age child, an adult who has a spouse, a friend, a co-worker, an employer, if it's an elderly person, to explain to the client themselves, but also to explain perhaps to their adult children and to other medical professionals, the CNAs, the nursing staff that interact with this patient. As we talked about already in this class, and we'll keep talking about, the reason it's important for you as an SLP to be able to explain speech recognition for persons with hearing loss, to be able to explain the audiogram, to talk about the implications of the audiogram is you are it. In most of the sites that we as SLPs work, there is no audiologist right there. There is no audiologist to turn to. And clients, their family members, other professionals turn to you as the SLP to explain it again. Help me understand it again. And I'll say this and keep saying this throughout the class. That is not an indictment of the audiologist who completed that audiogram. That is not an indictment of the otologist or the physician who made that diagnosis. It simply is a fact of human nature that when we get new information, especially information that might be disturbing to us, gee, I do have a hearing loss, or oh my goodness, my baby does have a hearing loss. Our ability to take in all of the details accurately kind of goes out the window. And so we need to hear it over and over and over again. So again, I don't want you, and I certainly don't mean that the audiologist who saw your patients or the physician who saw your patients did not do their jobs. They certainly probably did. But there's lots of research out there in the healthcare literature that says patients don't always absorb everything they're told, especially in the first encounter with a diagnosis. And because you're the person in the school system, you're the person that the child with a hearing loss maybe is coming to in a private practice. You are the SLP on site in the hospital, in the skilled nursing facility. Those questions are going to come to you. So Asha would clearly say to you, me, that as an SLP, part of my role is to be able to explain this audiogram. And if I don't understand it myself, or I'm a little shaky about that audiology course I had way back when, I'm probably not going to be as effective with my clients as I could be. So the two tools that I always say help me the most. They actually help me when I put on my audiology hat and practice audiology. I actually use these tools as an audiologist. But I also know that I use them a lot as an SLP. The familiar sounds audiogram and the count the dots audiogram and the information from the speech banana help me to try to put into realistic, understandable, patient-centered, family-centered terms what all these crazy numbers on that graph that's the audiogram means. Because oftentimes all of those words, hearing level, sensation level, SPL, sound pressure level, dB, hertz, cycles per second, frequency, pitch, what does all that mean? Remember how hard it was for you to learn it for a test? It's very hard for laypersons to get a handle on that. And so that's why these templates, the familiar sounds audiogram and the count the dots audiogram, that actually put the speech banana onto the audiogram. Give us a way of helping laypersons, our clients and their families, understand what does this loss mean in terms of my ability, my family member's ability, my patient or student's ability to actually hear and understand speech coming to them. So again, I want to encourage you to get started with that discussion, to begin to think about, can I explain this? Do I know how to explain it? I also put up in eLearn just a little 2-page Word document called Explaining the Audiogram. It's by an audiologist on the West Coast. And it literally sort of gives you a script, if you will, to explain to patients and their families what the audiogram means. And I often say to SLPs, you know, if this is not something that comes naturally to you, if you are a person who did not have an undergraduate course in audiology, and maybe now you've had a graduate course in audiology, but you don't look at these audiograms very often, sometimes simply having that little script in front of you as you go into an IEP meeting, as you go into a medical case staffing meeting, so that you kind of have on the tip of your tongue, how would I explain this? It's a good idea. It never hurts to have a little template, a little cheat sheet with you when you begin to explain what is the meaning of the audiogram. So that's your discussion question. So you have chapter questions and you have a discussion question. Can I clarify that, or have I said far too much already? Okay, let's do, again, stop me if you have questions. Let's talk about Chapter 2. And again, my goal is to not to make you audiologists. I get it. You are not audiologists. You do not have to know how to test hearing in a sound field booth, how to do ABR. That's diagnostic audiology, and that's not your role. You do not need to know how to fit hearing aids, or how to map cochlear implants, or how to determine which ADL is most appropriate and will interface with your client's CI or BAHA or hearing aid. That's the audiologist's role. But you do, again, have to be able to counsel about it. So you have to understand a little bit of it. And more importantly, you have to be able to assess as an SLP, what is my client's functional ability to recognize speech? Because the audiologist is so interested in fitting hearing aids, making a diagnosis, doing diagnostic audiology and fittings, that they are less interested in sort of that, well, what does this person really hear on a day-to-day basis in the multiple environments that this person interacts in? And so that really does fall to you. Believe it or not, you as an SLP, without all the fancy bells and whistles, the audiometric equipment and sound field booths, are going to be able to make some practical determinations about what your client hears. And that's really, for our purposes as SLPs, that's really what matters the most. It honestly doesn't matter at the practical level what a person can do in a test suite. What matters is what can they do when the parent is talking to a child, when a teacher is talking to a student, when two adults of working age are trying to communicate about a business transaction, when a senior in a long-term care facility is trying to explain to the staff what hurts, what do I need, what did you tell me to do. So it's that functional, practical, what do I recognize in terms of speech, that really is our question as SLPs. So that's really sort of, we're going to quickly review enough about the audiogram so you can be a good counselor, a good information giver, and then we're going to talk about what it is we can do. So tonight I'm going to do just a very brief review of Dr. Matlock's audiology class so that we can look at these audiograms. I know that Dr. Matlock taught you exactly what you need to know, but I also know that it was last summer. And that's a long time to go not using that information. So when we think about some of the things we're going to talk about and that your textbook talks about, beginning on page 42 and 43 in your textbook, it's important for us to look at why does the audiologist choose the materials that they use and what are the implications. And then, again, what is our role as the SLP? We're going to talk a little bit about multicultural issues. Fortunately, we are beginning to have more and more test materials available in some of the major languages. Your textbook actually does give you on page 86 some words that are frequently used in a Spanish picture identification task. And again, there are two different lists. There are some lists available in Mandarin Chinese, and certainly on an individual basis there are word discrimination, speech recognition lists available in many languages. I know there are lots of American audiologists that go particularly to Saudi Arabia, to Israel, and they clearly have local test materials. When we think about what it is that we need to ask, it is important, even as SLPs, that we sort of review from the medical chart that we can see, from a student's cumulative record that we would have access to, some basic patient history, because that really does dramatically influence how we choose to treat. So we do need to know the age of onset. Was this a prelingual onset of hearing loss, so that the person did not hear speech normally, either from birth or very, very early? Was it what we sometimes call a perilingual onset, meaning the hearing loss occurred sometime as the child was beginning to develop language? Or was it an acquired hearing loss, a postlingual hearing loss? That makes a really big difference, because the longer one had or is presumed to have had normal hearing, the more access to the auditory speech signal in any language that a person has, the easier it is to try to build oral language. So again, we have to think about age of onset, and we have to ask that question. We have to think about, was it, again, an acquired loss after speech and language developed, or was it presumably a congenital or perhaps very early onset loss? What do we know about the causes? Is this a hearing loss where we have a pretty defined cause? Was it a viral insult? Was it a noise trauma? Was it the result of some sort of bacterial infection? Or was it a genetic loss, and was that related to a particular genetic syndrome, or was that related to other types of early neonatal problems? Has it been progressive? That's a question that we always want to ask. And you, as SLP, can certainly ask these questions. That's not invading anybody else's professional space. You can appropriately ask those questions in order to understand your client better. So is this a hearing loss that seems to have gradually progressed over time? Is this a hearing loss that seems to be very stable, and once the hearing loss occurred, it hasn't changed? It hasn't changed in the last year, the last 2 years, the last 3 years. Is it a hearing loss that fluctuates? Sometimes there are some types of sensorineural hearing loss that fluctuate over time, particularly individuals with Meniere's. When they have a Meniere's episode or flare-up, their hearing will fluctuate. Children with middle ear pathology, maybe who just have middle ear pathology, or maybe children with sensorineural hearing losses and a conductive middle ear pathology, experience fluctuation in their hearing depending on the status of their middle ear functioning. One of the questions I always ask is, when did the patient or others first notice the hearing loss? With adults, we likely see that either the patient noticed it or others noticed it, and it may well be 2, 3, 4, 5 or more years before the adult seeks assistance. Does the hearing loss affect one ear or both ears? Again, I'm so old that when I was first trained as an audiologist, the standard advice was that if you have one good ear, you'll probably do okay. Now that is absolutely untrue. The research evidence that we have clearly confirms that unilateral hearing losses in one ear, are particularly devastating to children who are in the process of trying to learn language and learn literacy skills. That approximately 1/3 of the children with unilateral hearing loss fail a grade in school or require intensive special education. So what I said, what I was trained to say as a young audiologist, was simply untrue. So it certainly is true that hearing in one ear is better than very poor hearing in both ears, but it's not normal. We have 2 ears hanging off the side of our head for a very good reason. It improves our ability to discriminate speech in noisy environments. It adds modestly to the loudness of speech signals. It enables us to localize, tell the direction from which sounds come. And it's critically important, again, to children who are trying to learn their native language, or their second or third language, in a listening mode. So that's a question to ask. Another question for certain that you should always ask as you do a patient history is, what circumstances make hearing easier or more difficult? So you ask that of children who can respond to you and adults. You ask that of parents of even infants and toddlers and very young preschoolers. Can you tell me a time where you're pretty certain that your child actually heard you? Are there sounds in your home or in your daily routine that you believe your child hears? You want to get a sense of how that youngster is using, or perhaps not using, sounds in the environment. And then obviously you want to know, has there been any treatment? Have you ever seen an audiologist? Have you ever seen a speech-language pathologist? Have you ever had any auditory training, any speech reading training, any communication strategies training? Basically, this is just a quick review of the information from Dr. Matlock's course. Audiologists use pure tone audiometry as a quick way of trying to understand what the patient hears across the frequency range. We are looking at pure tone thresholds, which is the softest sound that the patient can respond to 50% of the time. Clinically, we do it in 2 out of 3 times. And we simply plot those softest sounds that a person can hear at each frequency that we test on this graph called the audiogram. We can test people in a variety of ways. Sometimes we test them under earphones, big earphones that block out all other sounds. Sometimes we test them with what are called insert earphones, and those are particularly preferable when we are looking at hearing aids, but also when we are looking at adults whose external auditory meatus, that external auditory canal, may become flaccid just as they lose tone in their skin, on their hands. You know how older people's hands look wrinkled? Well, it's almost as if their ear canal looks wrinkled inside, but it becomes flaccid. The cartilage begins to soften, the skin becomes loose, and so when you put earphones over older adults, you oftentimes collapse their canals. So that's one of the reasons that we try to use insert earphones, where the little microphone producing the sound goes into the external auditory meatus so we don't face that up or collapsed canal. We use bone oscillators with our audiometers to determine what does this person hear when we send the signal through the bone conduction route directly to the cochlea and bypass the middle ear ossicular chain. We often test them under speakers, essentially loudspeakers in the sound field booth, with the idea that if I put sound into the environment in a test suite, I'm at least simulating what that person receives in a listening condition when they don't have on earphones, they don't have on any amplification. So they're getting to use both ears at the same time with sound coming from loudspeakers. The list that you see on the right, you learned in Dr. Matlock's class. Those are the hearing loss levels. Those are the levels based on the pure tone average for adults. That table is on page 45 in your book. You also learned it again in Dr. Matlock's class. But that's basic information. I do want you to look on page 45 at that information about what is the effect on word recognition. So you want to be thinking about that the pure tone average, which is an average of the hearing levels at which a person can hear those frequencies, is simply a way to summarize a person's hearing status. So we use the average of the thresholds at 500, 1,000, and 2,000 to determine the pure tone threshold. But actually, you as an SLP, me, when I'm being an SLP, go, I don't really care about that. That's a shorthand way. It's a way to get a level. It's a description. But it's this table 2-1 on page 45. It's the effect of the hearing loss on speech recognition that's important for us. Because after all, we are speech language pathologists. We're interested in what is the effect of this hearing loss on a person's ability to recognize speech. So I really urge you to look at that table, 2-1. This table represents what it is like for an adult. Presumably an adult who learned speech and language through the auditory channel as a child and has lost hearing from some sort of accident, injury. The table that we looked at last week over in chapter 15 on the relationship between hearing loss for children is a table that reflects children. And you'll notice that there's some differences. What happens to adults who have good language skills, presumably, is different from the effect that a hearing loss might have on a child. So, again, you want to, in a way, sort of compare those and think about, okay, what happens for adults? And those of you who are interested in adults want to look at this chapter, 2-1. Those of you who are interested mostly in children want to go back to that table that we talked about last week on page 652, and it's table 15-6 that looks at the educational needs, the possible psychosocial impact. So again, sort of a different effect for kids. When you think about what the audiogram shows, the audiogram is going to show you left ear and right ear. It's going to show you air conduction. It perhaps, in most cases, will show you bone conduction. And it will tell you, by simply looking at it, if there is a difference between bone conduction and air conduction. If bone conduction is normal, meaning sound that bypasses the middle ear, where the sound directly stimulates the cochlea through vibrations of the skull. If that's normal, then the problem is in the middle ear, if there's an air-bone gap. If bone conduction is abnormal, and air conduction is also abnormal, and there's little or no air-bone gap, then we're looking at a sensory or a neural hearing loss. So again, you want to make sure that you are thinking about looking at this table on page 45 and thinking about in quiet or in unaided conditions, here's what this person understands. But you also want to make sure that as you read that table, that you think about in noise what that person is likely to miss. And you'll notice that for each degree or level of hearing loss, that noise complicates the situation even more. And that is particularly true of our older adults who are more affected by noise than younger listeners with the same degree of hearing loss. So noise has an effect on all of us. It makes it harder to hear. Think about yourself. If you're in a noisy environment, you're at a concert, you're in a very noisy restaurant, it is sometimes hard to hear. You find yourself trying to look somebody in the face to make sure you got everything. For older adults, in addition to that, it's more difficult in noise. Their ability to process information is gradually declining as a part of the aging process. And so you combine noise and this slow, very gradual diminishing of ability to process rapid speech signals, and you get more effects of noise. So again, we want to think about, did we read carefully the audiologist's report? Are we prepared to explain to the client's family member, whether this is a conductive hearing loss, whether this is a sensory neural hearing loss, which is generally associated with poor speech recognition skills, even with good amplification? Or is this a mixed hearing loss, where there's some problem in the middle ear and a problem in the sensory neural mechanism? Or is it perhaps a central problem? Is it a person whose middle ear, external and middle ear are functioning fine, inner ear, cochlea is functioning fine, maybe the early part of the eighth nerve is fine, but somewhere in the central auditory nervous system, higher up in the brainstem and in the auditory cortex, there is difficulty. That's a central hearing loss, and we certainly do see that. The other kind of hearing loss that we sometimes see as audiologists is this thing that we call a functional hearing loss. It's where there are psychological, psychiatric, emotional problems that are producing reactions in the patients that look like a hearing loss versus physiological problems. Dr. Matlock and I are actually presenting a really interesting adult functional hearing loss case at ASHA this fall. A person with PTSD that produced not a physical hearing loss, but a functional hearing loss. Okay, so one of the things that we want to think about in looking at an audiogram on page 46 and 47 in your textbook is to think about the shape of the audiogram across the test frequencies, because the shape, what we call configuration of the audiogram, markedly affects speech recognition. In general, if there is a flat configuration, so that the person's thresholds are within 20 dB of each other across the whole frequency range, that person, we oftentimes say, is a great candidate for amplification. We can simply, literally, turn up the volume. We can provide gain or additional sound across all of the speech frequencies, and that person says, oh, I can hear now. It's like the TV is down and you can't hear anything, and you walk over and you turn up the volume, or you take your cell phone and you go, oh, something's the matter. I must have turned the volume down. I can't hear. You turn up the volume and you hear. Those are the easy ones. Actually, they don't happen a lot. That's the top figure on page 46 in your textbook. The next thing that we want to look at is the bottom figure on page 46, figure 2.3, is an example of a high-frequency hearing loss. That's where the thresholds are within the normal range or near normal in the low and mid frequency ranges, but there's a sharp decline in the high frequencies. That kind of hearing loss is much harder to fit, but that kind of hearing loss is actually very characteristic of adults, particularly adults who have a presbycusic hearing loss, meaning simply an old age hearing loss. And sometimes that decline can be what we call precipitous at the bottom of page 47, meaning that loss is really sharply sloping. Sometimes we call that a ski slope loss. Goes along normal over at the top of the ski slope, and then it slopes down really fast. Those losses are very hard to fit. Now, our technology is so much better than it used to be, and it improves almost each year. And so we have gotten to where we can boost those high frequencies and not provide as much amplification or no amplification in the low frequencies. And we can do a frequency-specific pattern of amplification. And that's what the audiologist's job is. That's what they would have done for your patient if they fit a hearing loss that's a high-frequency hearing loss. They did their very best, given the technologies that we have, to make adjustments so that the gain can mainly in those high frequencies. But it's never perfect. Our audiology colleagues might beg to differ with me, but the honest truth is, for sort of practical purposes, it's never perfect. Hearing aids are not like eyeglasses. Even with all the wonderful improvements that we now have, hearing aids rarely, if ever, restore hearing to 20/20 hearing. There's no such thing as 20/20 hearing. But if we think about my vision as 20/20 when I put on my glasses, and that for many visual problems, we can correct the vision to 20/20. We can't correct hearing to 20 dB normal in many, many cases. So we do have to, I think, as speech pathologists, help our clients become realistic in understanding not only their hearing loss, but the fact that hearing aids are not perfect. They are not bionic ears, even though there's a cochlear implant company called Advanced Bionics. It's not truly a bionic ear. We also have on page 47 some examples of low frequency configurations where the person has a low frequency loss and relatively normal hearing, near normal hearing perhaps, in the higher frequency. That is a much less common configuration, but it certainly does happen. It's characteristic sometimes of congenital and genetic hearing losses. We also have something called the saucer-shaped hearing loss, sometimes called the cookie bite. It looks like a smiley face, looks like a bite out of a cookie. Again, that's another type of loss. Each one of those different types of losses presents some issues for the audiologist trying to fit that hearing loss. So you're going, okay, so what? The so what is that you, as the SLP, will be called upon many, many times, as I said earlier, to re-explain this to your client, to significant others in their environment, family members, other providers of services. And so it's important that you, one, have the words, and I gave you that little kind of two-page template from Dr. Meyer, audiologist out on the West Coast, that literally just says, here's what you say. Here's what the vertical axis of the audiogram looks like. Here's what the horizontal axis looks like. This is about pitches, like notes on a piano. This is about loudness. And he literally gives you verbiage. Again, many of you may say, I already know how to do that. That's fine. If you just need a little help, look at Dr. Meyer's little template. The other thing is to look at this familiar sounds audiogram accompanied with a speech banana for children, because the familiar sounds audiogram has there are many versions of it, I guess I should first say. There are many versions of it, but most versions of it tend to have cartoonish characters or little pictures of schematics of different sounds. So you will see leaves rustling at 10 to 20 dB. You'll see telephones. You'll see voices. You'll see jet airplanes, vacuum cleaners. And that's really a good way to talk about hearing loss for parents, teachers. The Count the Dots audiogram was actually developed by audiologists. It actually represents, again, the speech banana, which you see in your textbook on page 48, figure 2-7. And I also put another one up as an attachment to our news announcement in eLearn that's a little bit more detailed, that has the first formant and the second formant of the vowels, as well as the phonemes of each of the phonemes of American English. But that's a really important piece of information. The Count the Dots audiogram, literally from a lot of research, multiple studies of many, many different research studies, put together literally 100 dots to represent what is 100% understanding of speech. So literally, and those dots are squished up a little bit or they're spread out a little bit. Literally, if you look at that speech banana with all the dots, it's 100 of them. So it makes it easy to calculate what is the percentage understanding that a person would get for conversational speech in a mildly noisy background. And if you overlay the person's audiogram results, the X's and the O's, you can then see what does this person hear. Everything in the lower half or the bottom part of the audiogram is something the person can hear because it's above their threshold. Everything on the top part of the audiogram below their threshold, they don't hear. And you literally can count the dots and get a percentage. It's, again, often either one of those serve as a counseling tool. They provide a graphic representation of the effects of the person's hearing loss on speech recognition. Again, you will want to look both at their unaided thresholds, what does their basic audiogram indicate, that without a cochlear implant, without a Baha, without a hearing aid, here's what they hear. Oftentimes you'll be fortunate enough, particularly if you're in a school system and your educational audiologist has provided aided thresholds noted by a different symbol on the audiogram. You can talk about, here's what you hear, or here's what your child hears without hearing aids or cochlear implants. Here's what they hear with cochlear implants, with a hearing aid, with a Baha. So oftentimes we do those two comparisons. I put up in eLearn a short course on effective collaboration, looking at a presentation by an audiologist and an SOP, looking at how they collaborated to look at what the audiogram tells us, and then look at what the speech results are. And so what does that mean? How do we use audiometric information, then our speech results, and how do we then say, this is what it is like for this youngster or this adult when they are listening in a typical environment. The other thing I want to point out to you, did Dr. Matlock, I just need info, did Dr. Matlock show you all the Starkey app? Somebody tell me, does that sound even familiar? The Starkey Hearing Loss Simulator. Starkey's the name of a hearing loss company, makes hearing aids, and it's called the Hearing Loss Simulator. And you can access it from the App Store. There's one on Androids too. day. It is my favorite thing. When I'm, the word is hearing, sorry, not hearing. I apologize, my typing is terrible. It enables you, I mean, you simply download it. It enables you to choose an audiogram. So it has built into it mild loss, rising mild, gradual flat, precipitous. It has a whole bunch of audiometric configurations. You pick the audiometric configuration. It has a cookie guide. You pick the one that looks most like your client's audiogram. And then there is the familiar sounds audiogram with lawnmowers and cars and people and water, with the speech phonemes. So it essentially has the familiar sounds audiogram. You then can play what it sounds like to listen if you have that kind of hearing loss. You can use some stimulus that they've got in there, which is just running conversation, or you can actually record your voice, or a parent's voice, or a spouse's voice, and say, this is what your family member hears given their hearing loss. I actually find that is very valuable as a counseling tool. I have seen parents literally begin to weep when they realize that's what my child hears. I've seen spouses go, oh, I didn't know. Because no amount of verbiage out of your mouth, the physician's mouth, the audiologist's mouth, is as impactful as actually hearing it yourself. So I want to urge you that as SOPs, that's an app that you will, I think, find useful as a counseling tool. So it's the Starkey Hearing Loss Simulator app. And it's pretty accurate. It's not perfect, but it's pretty darn good. And because it's an app, it's called Starkey Hearing Loss app, Starkey HLS. But I think if you simply type in your search, if you simply type in hearing loss simulator, you'll get it. But Starkey is the, oh, well, Nicole, I don't know. I can't tell you why. All right, I'll keep looking to try to help you find it. Let me finish, and then I'll try to see if I can, because I'm looking at it right now on my iPad, so I'll keep trying to see. At the break, I'll try to see if I can get it. It is important that as we look at an audiogram, that idea that you're going to see some things, some numbers on an audiogram that relate to speech audiometry, and that's important. Something called the speech detection threshold or speech awareness threshold. That's important for us because it does tell us what is the lowest level at which the presence of speech can be detected by our client. So what's the softest sound our patient can hear? Oftentimes when we're looking at very young children or infants or individuals with significant developmental delays, we will simply get this speech detection threshold or speech awareness threshold because their vocabulary won't enable us to get this thing called the speech recognition threshold. The speech recognition threshold actually is the softest level at which a person can understand or recognize bisyllabic words of equal stress. Baseball, hot dog, sidewalk, armchair. That speech recognition threshold should compare with the pure tone average for toners. Now, it doesn't always, but it ought to be similar. When audiologists assess speech recognition, they will use a variety of different stimuli, different types of words. We oftentimes ask, what is the most comfortable loudness level that a person prefers? And that gives you, as an SLP, some idea. Does this person like a lot of sound? Do they need more sound? We test that. Okay, Kelly, that might be right. It may not be on, it won't be on the iPhone. I think that's right. It's on my iPad. It's likely that Starkey hearing loss simulator won't be on your phone because it takes more capability than your phone will have. So it is an iPad app. This speech recognition testing is tested with monosyllabic words that are phonetically balanced. So there are many of these lists available for audiologists to use that give us 50 words that are, again, monosyllabic. They're phonetically balanced, meaning the number of phonemes in that list of 50 words exactly matches the percentage of phonemes in running conversational speech. So there are more T, Ds, and Ns, S's, and vowels, fewer of the less frequent phonemes. And typically, we have the patient repeat the words. Now, that obviously is problematic for patients who have severe speech problems, obviously problematic for children who have very limited vocabularies. There are some other materials that we can use, and if you look on page 54 and 55 in your textbook, you will see, and 56, you will see a table 2.2 that has many, many, many types of tests that audiologists use. Words, sentences, phonemes. So we have lots of different choices. We typically present this material to the patient at approximately 50 or 60 dB. So we're trying to present it at a conversational level, and we're trying to ask, what does this person understand of speech at a conversational level? And we get a percentage score. That percentage score then will tell us, does this person understand 50% of speech, 75% of speech, good recognition at 90%? The audiologist may well introduce background noise to see what happens when there's noise in the background, not quiet. So we might present speech babble. We might present white noise, which just sounds like the radio off station. Cafeteria noise. There are lots of different types of noise that the audiologist can present as part of this background noise. Again, trying to get an impression of what does this individual, how does this individual handle noise? Again, the purposes of speech recognition testing on page 51 in your book are, one, to help the audiologist make a decision. Does this person need amplification? Are they really struggling to hear speech in common listening situations? We also use it to compare, is the amplification that we've recommended, the hearing aid, the cochlear implant, the bone-anchored hearing aid, or some sort of assistive listening device, is it really helping them? Can we look at their unaided performance without any amplification and their aided performance, and do we see improvement? We also use it to build confidence. We use it to compare two different hearing aids, two different assistive listening devices. We also sometimes, as audiologists, use it with patients to sort of help convince them that they really are having trouble. Sometimes they say, oh, well, yeah, sometimes I have a little trouble, but I really am just fine. But when you say, Mr. Jones, when we just did that test a few moments ago in the sound booth, you only understood 60% of those words I was saying. I would suspect that you're having more difficulty than maybe just a little bit on occasion. And sometimes simply that number, being confronted with, a low percentage score of speech recognition, is enough to have a patient begin to come to the realization that they do have hearing loss. It is impacting their lives, and to be motivated then to consider therapy and amplification. We also frequently test people in the auditory mode only, where we literally cover our mouths with a screen, an auditory hoop or a screen, where they don't get any visual information at all, and talk about, here's what you hear, without any visual cues. And then we repeat the assessment with visual information, so the person can combine lip reading and audition. Actually, that becomes the speech reading condition, vision and hearing, which is the normal listening situation for most of us most of the time in our daily lives. We oftentimes use that to help patients understand that looking is also important as well as listening, to encourage them that they can get some additional information by carefully looking at the person who's speaking to them, by actually doing some speech reading training that may enhance their limited auditory recognition skills. Again, a lot of times the audiologist is using speech recognition to decide how much benefit is the person getting from particular amplification devices, what are the kinds of environmental conditions, these noisy conditions, that are most difficult for the patient. Does the person need auditory training or speech reading training that might enhance their ability to function? So what are you supposed to do as an SOP? What questions do you need an immediate answer to as you plan a treatment program for your client. Pediatric client, adult client. You want to know the softest level at which the patient can hear. That's that threshold, the pure tone threshold, the speech detection threshold, the speech awareness threshold, the speech reception threshold. You also then want to know, can the patient recognize and understand speech at a conversational level? So can the patient detect and understand speech in quiet or in noise? Then you want to think, okay, so now I have a better picture of what my client can hear. And now I'm prepared to start talking about the implications that has for everyday listening. When we talk about how the audiologist tests the speech recognition, the audiologist is making decisions based a lot on patient variables. And if you look in your textbook from page 54, sort of through 60, 65, 70, there's a discussion of all of the things that would influence testing outcomes. And certainly as speech-language pathologists, we don't need much review on this. We know that age and maturity and cognitive status and linguistic competency, that communication mode, other disabilities, all of those things, of course, affect a patient's ability to perform. Again, this is part of Table 2.2 in your textbook, looking at choosing the correct stimulus. Again, there are stimuli that are phonemes only, where we are asking patients to discriminate ENE, EC, ED. That's important for us because it tells us, can they actually distinguish the different features of those nonsense syllables. For patients, that doesn't seem very realistic. They go, why do I have to listen to those things? That doesn't tell anything about how I hear. So again, sometimes that's hard to convince a patient. We can do it with adults, but it's very hard to do with children because they don't understand, why should I have to listen to this? For vowels, we tend to use monosyllables in that H vowel D form of a CVC syllable. He, who'd, had, he had. But again, not very much fun. So we tend to go with words, both with children and adults, but we also go with sentences. So we oftentimes use sentences and then count the number of words in the sentence that the person correctly identified. One of the things that you want to think about is on page 56 in your book, this is a little chart that's you're gonna use it in several different ways as we start designing treatment. When we think about stimuli that we could use, we can certainly use these nonsense, phoneme level discrimination tasks. But again, that gives us as SLPs lots of information. And when we train at that level, we know exactly what phoneme the person can or cannot understand. If we say they confused apa and aba, we know they didn't get the voicing distinction. They missed that feature, distinctive feature. If we go apa, and they confuse that with asa, we know that they are missing the friction out of the S. So using that detailed level of assessment, both in treatment and in assessment, that we as SLPs might do is important because it tells us exactly what feature the person is missing. If you look in your textbook on page 58 and look at table 2-3, you'll see something that looks like what was in your phonetics book. It looks like what you learned in RTEC. It is features, voicing, place, nasality. As SLPs, that makes a lot of sense to us, and we want to know which feature of these phonemes can you not get, Mr. Jones, or for a child, which features is Bobby continually making a mistake on? And that's what we need to train. Now that makes good sense to us, I think, as SLPs. We're down to the important distinctions for phonemes that we need to train in therapy for our patients. But it doesn't have much face validity. Again, people don't like to do those tests. Nonsense syllables just seem not interesting, not fun. And the other piece of that is that as listeners and speakers, we rarely are called upon to do that isolated feature discrimination. We typically have to understand speech in a running context where there are multiple cues from the environment, cues from the meaning of a sentence. So we do frequently then test monosyllabic words or bisyllabic words, or these special words that we use when we're trying to get a speech reception threshold, these fondies, like pancake. But we also test phrases and sentences because those have a lot more face validity. So again, audiologists will make different choices, but you as an SLP will also make different choices when you are trying to do follow-up testing of your patient's speech recognition in everyday situations outside the test suite, in the patient's hospital room, in your therapy room at school, in your office if you're seeing very young children, or in their homes. So again, you are making choices about which types of stimuli to use. Words probably have lots of face validity, and you can look at phonetically balanced lists. One of the ideas that's important in thinking about speech recognition is in your textbook on page 59, looking at this idea of lexical neighborhoods. A lexical neighborhood is simply a group of words that are similar. They can be similar acoustically, meaning they are comprised of a group of words that are acoustically similar and that have about the same frequency of occurrence. For example, fat, bat, mat, hat. They can also be words that are similar, but there are only a few words in that neighborhood. We call those sparse neighborhoods. Thumb, tea, lost. When we decide to test with a dense neighborhood list of words, that's harder because there are lots of choices to choose from. When we use sparse neighborhoods, there are not many choices. And so we may begin with a set of words that are sparse and that are very dissimilar in our therapy task, which we're going to talk a lot about next week, and move to using stimuli in dense neighborhoods that are very similar. So we're making those choices as SOPs in terms of initial assessment, but also in terms of designing our therapy materials. We also do use phrases and sentences because they have so much face validity. And we simply look at how many words a person got right out of a sentence, or if it is a group of sentences, what percentage of sentences out of a group of 10 or a group of 20 did the patient correctly do. I want to urge you that you as an SOP are perfectly capable of doing some of this testing. Now, you're not going to do it in a sound field. It's not going to be as controlled an environment. But it will certainly give you important information in terms of, does this patient need help, one, and then where do I start in therapy? So if you look on page 79 in your textbook, you'll see the lexical neighborhood test. There are two lists of words, one that's easy and one that's hard, and then another second list with easy and hard words. You can administer that test, again, to your patient in the therapy room or in the patient's room in the hospital and determine what percentage of those words do they correctly identify. You will want to, and we're going to talk about this in just a minute, you will want to administer that assessment both auditory only, where you eliminate any visual cues using an auditory hoop, and we're going to talk about how to make one. It's an embroidery hoop with acoustic cloth like your speakers that lets sound pass through, but no visual clues. So you're going to administer those tests auditory only, and then you're going to administer them auditory and vision to help you get a sense and the patient get a sense of how much additional benefit, called the speech reading enhancement or auditory enhancement, how much help do they get by looking and listening? If you'll look on page 79 in your book, you'll see something that's called the CID sentences. We're actually going to use these sentences in a later discussion after midterms and after comps. But these CID sentences were developed a very long time ago at the Central Institute for the Deaf, and there's a list of 10 different lists of 10 easy sentences. Walking is my favorite exercise. It would be much easier if everyone would help. I'll think it over. So again, simple everyday sentences. Typically children above age 10 can do these, so that's about the vocabulary level. Certainly middle schoolers and adults can do them. They have a lot of face validity. And we use them often to do this assessment of our patients as SOPs. These are not audiology only test materials. They're practical everyday sentences that you can do with your patient to give you a sense of what does my patient hear. First with full face visual and auditory cues. So I'm doing audition plus vision. Then I can do it with audition only. I can cover with an auditory hoop or auditory screen my mouth. So the patient really can't see. They're dependent only on their hearing. I can do it vision only by simply completely decreasing the output of my voice. Now you have to be careful that you're not over-articulating, but you can literally mouth the words. You then can add noise. Maybe all you're going to do is turn on a radio or turn on your phone with just some soft background music. Maybe you want to see what this person can do in a noisier environment. So you add a little white noise, the station off the mark, or just running babble. Again, they are not perfect, and most audiologists would go, oh my gosh, it's not controlled stimuli. You don't know exactly. And I'm going, I get that. But as a practical matter, as an SOP, it gives me very valuable information for being able to say, what can my patient do right now at baseline? And then I can train where they're having difficulty and then repeat those measures, or at least some of them, after therapy and go, see, the patient made gains. So it's really not a complicated idea. It's just, do I have the materials I need? In your textbook on page 84, there is actually a test that's used with children that Nancy Murray and Ann Gears, who was a teacher of the hearing impaired and SOP at the Institute for the Deaf for a long time, developed, called the Children's Audio Visual Enhancement Test, the CAVIT. And again, it has 3 lists of words, easy and hard, by vision only. There's also one on page 85 called the Quicksand, which is a list of sentences. And they are frequently used by audiologists, and they are presented in a background of noise. So there are lots of different types of materials that we can use to get a more realistic picture. One of the questions oftentimes in doing these kinds of assessments that we have to ask is, do we want to do these in an open set format where the person just has to repeat back what they hear, where they just have to say the sentence? Or do we want to do them in a closed set format where the person has 5 pictures to look at or 5 simple sentences to look at? So it's a closed set. Obviously, closed set is easier, and we're going to talk about that next week when we talk about therapy materials. It's always easier if it's a closed set. Think about yourself when you take a test. If they're multiple choice, at least you've got 4 or 3 or 5 to choose from. That's closed set. Open set is where there's this big blank and you have to generate the answer. That's harder because there are no choices provided. So we have to think about, for our patients, is our patient's cognitive level, our patient's motivation, our patient's stress level, if nothing else, such that they need to start at a closed set. And we oftentimes do lots of therapy at a closed set level. But the goal would be for our patients to be able to understand speech in open sets, because in the real world, people don't give you picture choices very often. While we may do closed set as a training procedure or a testing procedure, open set is the ultimate response format. The audiologist, of course, goes for recorded test material. You can control the stimuli. As SLPs, we oftentimes do use live voice. Live voice is oftentimes patients react to that as more realistic. You can control your speed, your rate. You can control when you present the stimuli. You can adjust your presentation rate for a young child who has poor attention, for a senior who also is faced with attentional difficulties. So we as SLPs oftentimes do use these assessment procedures for speech recognition using live voice. We have to be aware, and we have to acknowledge that that introduces an uncontrolled variable because it changes. We don't have as good control over the stimuli. It's also true that we will talk about at the end of this class the use of synthesized and altered speech. Synthesized speech is obviously computer-generated speech. Altered speech is human speech that was recorded and then altered in some way. Maybe the timing of the speech, the time was compressed, or maybe it was expanded, or maybe we cut out all the low-frequency information, or we cut out all the high-frequency information. So we manipulated or altered the speech. We often use those kinds of stimuli when we test central auditory processing, both in adults and in children. We're putting stress on the auditory system to be able to understand speech that has been altered in some way. So we use it as a diagnostic tool to generate difficult speech listening conditions. We also have to think about all of our speech recognition assessments being subject to learning effects. So that's one of the reasons we have multiple lists, so that we are trying to minimize as much as possible the learning effects. And we need to be thinking about that as we do our assessment, our pre-test and our post-test. We use equivalent lists. That's what all these lists are that are A and B, and they're essentially equivalent. So we have to be thinking about that. Another issue that Nancy Timerly introduces only briefly, but we'll keep talking about it, is this issue of multicultural issues. And we certainly talked about that a good bit in the spring. We talked about the fact that when we are addressing the needs of patients who are bilingual or semi-lingual or have had early exposure to one language and maybe more recent exposure and current exposure to another language, we have to really think about when we are assessing hearing acuity and speech recognition, what is the language at which we can get our patient's best performance. But it's also true that we want an estimate of what our patient can do in the languages that they are currently being exposed to. So again, we oftentimes will try to assess in L1 and in L2. The advantage of using something like that picture identification test in Spanish is that you, as the clinician, don't necessarily need to be absolutely fluent in that second language, whether it's Spanish or Chinese or Arabic. You have to be able to present the stimuli appropriately, but you can use that. Again, you can use an interpreter to do that, and then the patient simply points to the picture-based stimuli in that closed set frame. So what's important, I think, for us to take away from this chapter 2 in this textbook is to recognize that the audiologist is going to do their thing, and they're going to send us an audiogram, and they're going to hit explain that audiogram to the patient. But we, in order to design a treatment plan as an SOP, have to extend the assessment beyond the audiometric test data. We have to actually ask, what is the impact of this hearing loss on the client and their frequent communication partners in the environments wherever they live and function? And we have to have more information to plan treatment goals, because an audiogram isn't going to give you the treatment goals. So when we think about what we do a detailed case history, and we ask those questions that we talked about at the beginning of the hour. We also very frequently use questionnaires and self-assessments, and we're going to be talking about a lot of those as we move through this course. Any of these questionnaires and self-assessments that are at the end of the chapters in this timely book, you as an SOP can certainly use. They are not, the vast majority of them are not copyrighted. They were published as part of research literature. You can use them to get a sense of what your patient can or can't do, how they are responding to the different instruments, devices that they have. You can also spend a good bit of time with frequent communication partners. They will give you a lot of information. The spouse, the caregiver, the teacher, the parents. Oftentimes those people recognize the problem when the patient themselves doesn't. And so having the frequent communication partners share with you their perceptions of the difficulty that the patient is having is really important. You certainly want to use live voice testing with controlled materials, controlled speech stimuli, but you want to test auditory only and auditory vision so that you get a sense of, one, is your patient getting improvement or enhancement in the auditory vision mode? Why or why not? And do they recognize the need for speech reading? So you want to be thinking about that. Remember, ASHA clearly says that your role as an SOP is providing services to individuals with hearing loss and their families and caregivers. So you're going to provide auditory training, speech reading, speech and language intervention, if they need that, if they are individuals learning speech and language, you're going to provide that. You're also going to do visual inspection and listening checks of their amplification devices for troubleshooting and verification of battery voltage. And that's what we're going to talk about after we take a little break here. So our job is counseling and education. We are going to have to, again, talk about the hearing loss, talk about the impact of the hearing loss, help all of these people that are part of our treatment plan, not just the client, the family, the caregiver, the teacher, the employer, learn effective steps to manage the loss, strategies to overcome the challenges they face, and we're going to have to be able to communicate in easy to understand, patient-friendly language, exactly what the audiogram means. We're going to be doing a lot of informational counseling. The nature of the hearing loss, ways to manage it, what does it mean? We will also do, as part of our role, a good bit of personal adjustment counseling. Again, we'll talk more about that in the section in your textbook on counseling, particularly Chapter 10. And we'll talk about, again, targeted counseling. So again, our ability to adequately serve our clients is directly correlated with our ability to understand the audiometric data, our ability to competently conduct extended assessments beyond just what does the audiogram say, but how does this person respond to speech visually and auditorily in the real world environment, to be able to interpret those data, to put that interpretation in the context of our patient's life, and to counsel and educate the client and the communication partners about the nature and the impact of the loss and strategies for managing it. So again, we are part of a team. We oftentimes are the linchpin, if you will, in the team, because we see these patients on a day-to-day basis. We're in a school, we're in a hospital, we're in a long-term care or a SNF. So we are the feet right there on the ground. We have that contact, whereas the physician and the audiologist are more removed. Now, we're not trying to take over their roles, but we are the intermediary often for our patients. Why don't we take a little break? I will certainly come back and answer questions about this material, and then we are going to move right on into talking about hearing devices, hearing aids, cochlear implants, FM systems, hearing-related technologies from Chapter 3. So let's take a quick little break, and then we will come back. Let's come back in 5 minutes. So I have it 7:26. Let's come back at 7:30. Okay. Okay, are we ready to get started again? We'll give everybody a minute more to get back. Questions, while we give everybody a little bit of time, that I can answer, something I can clarify. Is everybody okay? Nicole, I don't have the answer. I have asked, and I will try to figure that out. I will press Dr. Smith again on that. Thank you for asking. Okay, we are going to move on in our Nancy Tom Murray text to Chapter 3, Listening Devices and Related Technologies. I certainly understand that, Nicole. Thank you for reminding me. I've made that argument on many occasions. We're going to talk about listening devices and related technologies. Again, the goal of this class is certainly not to make you as an SOP into a dispensing audiologist. That is well outside your scope of practice. So that is not our goal. Our goal is to think about, though, what is our role as SOPs vis-a-vis these devices. And again, because we are the boots on the ground, we are the people who have the most face-to-face daily contact with our patients with hearing loss, we need to be knowledgeable about the basics of amplification from our role as an SOP and to help and counsel our patients and to manage the devices that have already been fit by a highly competent audiologist. And believe you me, that's plenty to say grace over. So I put up here just some little pictures of different types of devices. A cochlear implant device, a receiver in the ear device, a typical behind the ear hearing aid, in the ear hearing aid, completely in the ear, and a deep in the ear device. There are many, many types of devices. Again, you will see patients with all sorts of different types. So we're going to do a brief overview of hearing aids, cochlear implants, and assistive listening devices. I think the thing that's important for us to think about is that the goal of any kind of technical device for a person with hearing loss is to provide optimum gain or output for the person, to optimize the speech spectrum characteristics so that the person has auditory or acoustic accessibility of environmental and speech sounds relative to what they get without any amplification. Excuse me. So again, the goal is to make speech audible without distortion or discomfort, and to restore where we can the range of loudness that we as normal listeners experience. We hear soft sound, moderately loud sound, and very loud sound. So we have a sense of intensity. When we think about hearing aids, we recognize that there has been incredible improvement in the technology over the last 50 years. And your textbook does a little table on page 89, just looking at landmark events in the history of hearing aid technology and marketing from major companies. Again, as you work on your communication modalities project, you'll want to be looking at the websites of those companies listed on page 89 in table 3-1, because those are the major manufacturers of hearing aids in this country at this time. And they all have very robust, very extensive websites. You'll also want to be looking at Appendix 3-1 on page 136 and 137, because that's where you see, again, the listing of these companies that will send you materials where you can find materials that will enable you to complete your project. So when you say, where do I go to get all this stuff, Dr. Fitzgerald? Well, where you go are these websites, and the first set on page 136 is the major manufacturers of hearing aids. At the top of 137 are the 3 companies that sell cochlear implants in this country. And at the bottom of page 137 are the major companies that offer assistive listening devices in this country. So those are the places that I would start as I was beginning to collect materials. Again, these commercial manufacturers are companies who are out to make a profit. They want people to adopt, purchase, use their devices. And so they provide a lot of patient and consumer information and support and help. So when you say, okay, what kinds of artifacts would I collect to help me help my patients, use these manufacturers. These manufacturers actually see you as an SOP as an important part of their public relations. They want you to know all about their devices. They want to give you therapy materials and help for patients and their families, because they know if you're knowledgeable and you're sharing that with your patients and you are assisting your patients, the patient is going to be satisfied with the device. The patient then is going to tell others that I really love my Oticon hearing aids. My Advanced Bionic CI is wonderful. I love my Baha. And they sell more of their product. So please do use these resources on page 136 and 137. If we think about what used to happen, and your little table goes back to 1847, if you think about what used to happen for people who are deaf and hard of hearing, we didn't have technology, or we had very limited technology. So we would speak more loudly. I mean, literally, we would shout at people. We would talk right into their ear. There was a whole approach to teaching deaf children that really involved teachers and parents talking right into the ear of the child, which would increase the loudness some, for those who had moderate and severe and moderately severe hearing losses. Or we used what was called an ear horn or an ear trumpet. So we laughingly talk about that was the technology until approximately the mid-50s, the middle of the 1940s and 50s. As we began to be able to miniaturize the power source, we developed batteries that were smaller. And then, so we could get hearing aids that weren't big boxes. They were smaller and smaller and smaller and even smaller. And we developed what we call signal processing strategies. So rather than just turn up the volume, add to the gain, we could manipulate the signal. We could raise the high frequencies more than the low frequencies. We could adjust the frequency response of hearing aids. So we've seen tremendous improvement. One of the most important improvements that we have is that we now have hearing aids that have what we call multiple memories. And multiple memories are essentially different programs within the hearing aid that the patient has control over, or if it is a child, the parent or teacher can control, or, believe it or not, if it's an elder, a senior geriatric, who can't manipulate his or her own hearing aid, or has cognitive issues and can't manage the complexity of switching something about their hearing aid, there are remote control devices that enable others to remotely control these different programs. If you look in your textbook on page 98, you'll actually see a picture of a handheld remote control that enables a parent, a teacher, a speech pathologist, a CNA, a nurse, to actually adjust these different programs. But the advantage of multiple memories is the patient may need one type of gain and frequency response in a really quiet environment, and another type of frequency response and gain in a noisy environment. One type of memory to listen to a concert, another to do face-to-face talking, another to do a large group discussion. So many of our hearing aids are enabled to build in these different programs so that the patient has control over the degree of amplification, the frequency response, and the gain for different types of listening environments. Almost all of our hearing aids now have what is called acoustic feedback cancellation. So that idea that the hearing aid whistles. How many of you have ever heard someone complain about a hearing aid that whistles or squeals? That used to be a very real problem. Adults really didn't like that. Teachers in classrooms really didn't like that. Children, when they would get with very powerful hearing aids, because they had very profound hearing losses, when they would reach up and touch their head, oftentimes would get feedback. Feedback is really just like a microphone feeds back. It's the sound coming out of the hearing aid and feeding back into the microphone of the hearing aid. And it used to be a real problem. And so people would simply turn the hearing aid down to avoid the feedback and in effect turn it off. They turned it so far down that there was no amplification coming out, and therefore no feedback, no squealing, but no benefit to the patient. So we now have hearing aids where we can control or cancel that feedback through the programming of hearing aids. We also now have lots of programming ability. The audiologist can set the gain, the frequency response, and other electroacoustical properties. And again, we can remotely control those if necessary for individuals who really can't manage those programs. Almost all hearing aids now in this country and in Europe use digital processing. Digital processing simply means that the signal is converted from an analog signal to a digital signal, and then it's the digital signal that's processed, that's changed to achieve the target gain and frequency response. And then that digital signal is converted back into an acoustic or analog signal. And almost all hearing aids, again, do that. We also have multiple channels on our hearing aids now. We are looking at information from page 90 to 91 in your textbook. Multiple channels simply means that the signal processing technique whereby we're changing this incoming signal from the microphone and enhancing it, we can divide it into different frequency bands so that, again, we can boost high frequencies versus low frequencies, providing more gain or amplification to the place where the patient needs that gain. Maybe they need low frequency gain because they have a low frequency hearing loss, or they need high frequency gain because they have a high frequency hearing loss. Well, so again, we have a lot of technological capability that has made hearing aids much more effective. I want you to look very carefully at page 91 in your text, because there's a schematic of a hearing aid. And I think for us as SOPs, if we simply understand this schematic, then all the bells and whistles, all the neat new colors, neon blue and sparkles and leopard prints, and I mean, hearing aid manufacturers have got it that cosmetically they have to make these devices appealing and attractive. But mostly that's just what they are. They're cosmetic. The case looks different. The colors look different. It's still the same basic components. This schematic is important, I think, for you to know. It's important for all of us to understand a hearing aid really is nothing but a microphone, an amplifier, a receiver, and then some sort of battery to provide power. The microphone picks up the sound from the environment, speech and other environmental sound, and it converts that acoustic signal that it picks up into an electric signal. Microphones can either be directional, meaning the microphone is really just picking up what's directly in front of it. It's not picking up sounds behind it or to the side. Or it can be omnidirectional, meaning it's picking up sounds all around, back, front, side. It depends on what the listening environment of the person is as to whether a directional microphone, an omnidirectional microphone, or what now we have are automatic directional microphones where we can switch from one to the other. What is the listening environment that the patient is in? Are they primarily in simple face-to-face interactions? That's when they need a directional microphone. But are they busy in a world of work or in other activities where they do want to hear conversations behind them or beside them, and that won't be distracting to them? So again, microphones pick up acoustic signals from the environment. They convert the signal into an electric signal, and then they send that electric signal to essentially what's an amplifier, just like on your stereo system. The amplifier is where the signal, now that's digital, is amplified. It's amplified high, low, both high and low frequencies. That amplifier, the whole hearing aid does have a battery that's generating the power. But the amplifier is a component of all hearing aids, and it's essentially the workhorse of the hearing aid. The amplifier then amplifies or puts out a louder signal. That a louder signal is electric. It's then converted into an acoustic signal that goes back to the patient's ears. The receiver is called a receiver out of the old telephone technology. If you look in your textbook on page 95 and 96, up at the top of page 96, there's a little box, text box that says, why is it called a receiver when it's sending out a signal? It's not receiving the signal, it's sending the signal out. It goes back to the old days of the telephone. Remember, Alexander Graham Bell invented the telephone. He also invented hearing aids. The first big laboratories in this country that developed hearing aid technologies was Bell Laboratories. The big telephone maker, Ma Bell, AT&T, in its deep, dark history. I mean, a funny little story, but that's why it's called a receiver. Many of you who are old will remember your grandmother or your grandfather's telephone, that thing that sat on a desk where you picked up a receiver. I actually have one in my office at TSU. That's what we talk on at TSU. The telephone receiver, that's sending out the signal to you. So sort of just a little piece of history. But the receiver is what we call that part of the hearing aid that takes this electric signal, converts it back into sound energy. The receiver now can be a wide variety of different shapes and forms. Sometimes it's just tubing that goes into the patient's ear. Sometimes there's actually a little button-type receiver that hooks to an ear mold that is especially designed for the patient's ear. So the ear mold delivers sound from the receiver to the ear, and it holds a hearing aid in place if it's a heavier hearing aid, a behind-the-ear hearing aid that's heavier. Ear molds are custom made to fit into the patient's ear. And for young children, ear molds have to be remade often because children's ears grow just like their feet. Those of you who are parents know that little children outgrow their shoes really often, sometimes every 3 months, every 6 months. I always used to say to parents, when your child needs a new pair of shoes, he or she may need new ear molds because his ears gotten bigger. That's when you oftentimes get this feedback because the ear mold is too loose in the ear and it falls out. Many adults now use tubing, that receiver in the ear, and that's the only receiver mechanism, not ear mold. Ear mold can be half ear molds or shell ear molds so that the individual can hear some environmental sounds. So remember this schematic and help your patient see a hearing aid really is a pretty simple device. It has lots of bells and whistles, but actually it's pretty simple when you think about it. Again, the amplifier is the workhorse. It's designed to increase the amplification, the loudness of the signal. Gain is an important term for us all to know. We measure all hearing aids in terms of the gain, which is the difference between the input sound and the output sound. So it's simply how much boost or amplification or gain, all of those would be ways of saying the same thing, that the hearing aid is providing. There are two ways to amplify. One is this thing called peak clipping. These are actually pictures from your textbook, page 94 and 95. Because it is possible to amplify sound too much, meaning the sound becomes uncomfortable, there isn't built into all hearing aids as a safety factor this idea that there's a maximum power output that the hearing aid would provide. So it doesn't further damage a person's hearing by literally blasting them out with sound that's way too loud, uncomfortably loud, damaging to whatever residual hearing they might have. And many strategies for controlling that was this thing called peak clipping, which basically says when the sound gets too loud, we just clip it off. We just stop amplifying. That led to a lot of distortion. And so manufacturers began to develop this thing called compression. So the amplifier gain, when it gets to that too loud, rather than just cutting it off, they compress the signal. So the person gets the full range, it's just not as loud. So they develop a compression circuitry. Not that you need to understand all of those acoustics, but when somebody says, oh, I've got a new compression hearing aid, that's what they mean. Again, hearing aids have off-on controls, most of them. They have volume controls. They also, many hearing aids have what are called telecoils. And the reason telecoils are important is that the telecoil is an induction coil within the hearing aid. It's literally a piece of wire around a magnetic rod. But it enables the hearing aid to pick up signals through the telephone receiver without going through the microphone. So the person who has a hearing loss, wears a hearing aid, is trying to listen over a traditional telephone, can turn on the T switch, the telecoil switch, and receive the electromagnetic signal from the telephone. and get a better, higher quality telephone signal than if it goes through the audio signal. The telecord decreases acoustic feedback, decreases environmental noise. Telecores are oftentimes used in large-scale assistive listening devices. So if you go to church or synagogue or temple, you go to a symphony concert, a large auditorium for a speech, that large auditorium may be fit with assistive listening devices for people with hearing loss, and the individual with a hearing loss and a hearing aid flips their hearing aid to the T telecoil and then receives a much higher quality acoustic signal without using the microphone of the hearing aid. So we want to be thinking about what that looks like. I put up just a little schematic that maybe helps you sort of figure that out. Those are the kinds of things that we talk about when we talk about assistive listening devices for our patients. So here we go with the different styles of hearing aids. There's completely in the canal, half shell. See that little thing? It's not a full ear mold receiver. It's just a little shell receiver. Receiver in the ear, fits behind the ear, and this little tubing and this little shell that keeps the tube in the ear, widely used now. In fact, this is one of the most common types of hearing aids sold in this country now. Really small behind the ear, and then this thin, almost invisible tubing and a little shell that keeps it in the ear. An open fitting, again, neat, triangular, multicolored case, and then just clear tubing that goes in the ear. A more traditional behind the ear hearing aid, where the hearing aid is behind the ear. There's an ear hook right here, and then it is connected to an ear mold of some variety. Generally, what we see is that when individuals need very powerful hearing aids because they have severe and profound hearing losses, we see that the case is bigger simply because it needs more power. So we can fit any hearing loss with a behind-the-ear hearing aid now, even our most profound hearing losses. But we tend to fit them with what we call power aids that are larger. These completely in the canal hearing aids, half-shell hearing aids, work well for mild and moderate hearing losses. They eventually do not have enough power to fit severe and profound hearing losses. We still sell, there are body aids, which is literally the old-fashioned hearing aid, with a case that's about the size of a deck of cards, not really, more the size of a box of matches. But it has an microphone, amplifier, and receiver, just like every one of them, an ear mold. It is used for severe and profound hearing losses. It is bulky, it's highly visible. You have to wear the body of the amplifier on the shoulder, the pocket, the belt. Every now and then we will fit someone who has an atresia, meaning they have no ear or only a malformed ear, and we can't fit a behind the ear or an in the ear hearing aid. So occasionally you will see those, but very rarely. Mostly we see these behind the ear hearing aids, and this is what one looks like, a fairly large one that certainly is the size that would fit any hearing loss. They are easier to clean, have fewer repair issues. We can hook them to a wide variety of assistive listening devices. They almost all include telecoil. But again, there's still that issue particularly for many adults, that they're visible. And so they're cosmetic issues. We have the in the ear and in the canal hearing aids, and here's some pictures of those. Many of these, especially the in the canal ones, are so small that they don't always include telecoils. So they may not serve a person well who goes to a lot of public events where there are built-in amplification systems for the hearing impaired. We have these completely in the canal hearing aids. They have some real advantages, but again, they're too small for telecoils. They are easy to insert and remove if you have good manual dexterity. But if you are a geriatric and you are beginning to lose some sensation in the tips of your fingers because of diabetic neuropathy or other issues, they are very hard for some seniors to manage. So we need to be aware that there are different reasons that we may not see this type of completely in the canal aid in our seniors. They also can fit mild, moderate hearing losses, but not severe hearing losses. You do want to look in your textbook at table 3-2, which sort of is on page 104. It sort of gives you a rough idea of what these different devices are and what type of hearing loss they're going to fit when they're not optimum or when they really won't be effective. Because oftentimes you as the SOP have to help families understand why this particular style that they may want really isn't appropriate or won't be appropriate if the loss is progressive. We typically recommend binaural hearing aids because you have two ears that work. That's the normal listening mode. And we want our patients with hearing loss to have that access. Binaural amplification is generally better than monaural or single ear amplification. And so oftentimes audiologists will recommend that. Some patients, particularly geriatric patients, may choose on a cost basis alone not to have two hearing aids, just to have one. Certainly in cases where there's a unilateral hearing loss, people may have just one hearing aid. The advantage of binaural hearing aids is that they eliminate this thing called head shadow, so that if you, as a normal listener, hear a sound from your left side, that sound comes to your left ear sooner and louder, then it comes to your right ear. That head shadow prevents the sound from getting to your right ear quickly and loudly. That's how you tell that's how you localize sound. It's also true that two ears provide some loudness summation. So sound from both ears is a summing of the signal, and it increases the loudness by about 3 dB. The real important advantage of two hearing aids or two ears or binaural hearing is that it squelches noise. We talk about binaural squelch. Being able to hear through two ears improves speech recognition in noisy environments. And obviously, that's what our patients most often complain about. So two hearing aids is going to help listening in noise. We almost always recommend two hearing aids for children, and because there are Medicaid pays for them, all insurance policies must offer that option for children with diagnosed hearing losses. So rarely do we see a child who needs binaural amplification not having that available to them, because the cost factor that influences seniors and adults' decisions is not an issue for children. So again, we certainly want to look at binaural amplification where we can. When we talk about people who have cochlear implants, we oftentimes have binaural implants. But we also have individuals who have a cochlear implant on one side and a hearing aid on the other side, because the quality of sound that you get from a cochlear implant is different from the quality of sound that you get from a hearing aid. Hearing aid is acoustic stimulation. Cochlear implants that we're getting ready to talk about are electric stimulation. And many individuals, particularly those who are musicians, particularly those who are multilingual and like being multilingual and use both or more than 2, maybe 3 languages, say that they prefer oftentimes this, what is called bimodal stimulation. So bimodal means 2 modes. It means CI plus a hearing aid. And oftentimes users will tell us that they actually like that CI plus a hearing aid best. CI plus a hearing aid gives good speech perception in noise and quiet and better improvement in localization. Some people like 2 CIs. They do well with that. So again, some of that is a preference by the patient. We now are seeing CIs implanted in people of all ages, 70, 80, 90-year-olds who are in good health otherwise and are motivated and cognitively intact to manage cochlear implants are being implanted more and more. And I actually put up something in eLearn about CIs with older adults. So when we think about assessing hearing aid benefit, the audiologist is going to do what we call verify and validate the results. Now that audiologists fit hearing aids with a prescription procedure, meaning they set a particular gain and a particular frequency response, boost the highs, boost the lows, boost the mid frequencies a certain amount. When the patient actually receives the hearing aid, the audiologist then verifies that, in fact, the hearing aid meets those standards. So they frequently use behavioral techniques where they administer those same speech recognition tests without the hearing aid, then with the hearing aid, and they look at the percentage of words correct. They also almost always do probe microphone assessment. So they actually put a tiny little microphone on a little tube into the ear canal, very near the eardrum, and the microphone, this probe microphone, records the decibels of output at the end of the ear canal. It's measuring the gain that the hearing aid actually is producing in that person's ear at each frequency. And then it compares, the audiologist compares that to what did I set the prescription for, and is the hearing aid delivering the prescribed gain at each frequency. You're not going to do that. That's the audiologist's job. The audiologist may also assess that hearing aid by putting it in what we call a hearing aid test box. So they put the hearing aid into a box coupled to a 2 cc coupler, and they put sound into the hearing aid and they measure electroacoustically what comes out. If you look in your textbook on page 106, there's a description of the electroacoustical properties that the audiologist is looking at in that hearing aid test box. Again, that's not your job, but we oftentimes, when we find a hearing aid, you and me as SLPs, parents, teachers, nursing care staff, find a hearing aid that's not working, and we can't troubleshoot the problem ourselves, which we're going to talk about. We send it back to the audiologist, and we ask the audiologist, will you evaluate this hearing aid because we think that there are more problems than we could troubleshoot with our simple procedure. And they will then put it in the test box and see what electroacoustically the hearing aid is actually putting out. Send it back to the manufacturer for repair if necessary. What we as SLPs often do to assess the benefit of hearing aids is we use these subjective procedures. We ask the patient to do a self-assessment. We ask significant others in the environment to do an assessment. There are a series, many tools that we can use. That are, again, these assessments that are self-assessments or other significant partners that the person has. If you look on page 109 in your textbook, you will see a table of lots of these tools. So these are essentially self-report measures that help us get a sense of, is the patient saying the hearing aid helps me or the hearing aid doesn't? So we want to think about using these. You can use these. These are all widely available. They aren't special for the audiologist. You could ask patients to fill out satisfaction with amplification in daily life, the saddle. You could ask patients to fill out this thing called the AFAB, the abbreviated profile of hearing aid benefit. so that you and the family get a sense of, is this patient saying to us, the hearing aid is helping me? Or is the patient saying, no, this hearing aid isn't helping me? So again, there are many, many of these tools that can be used by SLPs as well as by audiologists to talk about what is the impact of the hearing impairment on the patient's daily life. Does the hearing aid make a difference in improving those daily situations? The other thing that we need to talk about when we talk about hearing aids is what is it that audiologists do when they orient their patient to a new hearing aid. Every audiologist, as a matter of ethical practice, when they fit a patient, does hearing aid orientation. They want their patients to like their hearing aids, to keep their hearing aids, not to return them for a refund. So they have every reason to try to do a good hearing aid orientation. But the problem is that they do it typically in one quick visit. And many patients, both parents of children and adults, and certainly seniors, need more than one repetition or one modeling. But basically, this is what an audiologist covers in that hearing aid orientation. They describe the hearing aid, they teach about the controls, they help the patient learn to insert and remove the hearing aid, they talk about how to maintain the hearing aid, they talk about how to use the hearing aid on the telephone if it has a telecoil. They talk about limitations or expectations. They talk about how to troubleshoot the hearing aid. They must provide printed information about return policies and warranties. But you're going to learn in this class that you need to do that again for many patients. As an SLP, part of your counseling role, part of your support role. What we just saw, Asha said, our role is that we're going to have to do the ongoing hearing aid orientation and monitoring and follow-up. We're going to have to teach teachers and CNAs how to do this too. And we're going to talk about that in just a very few minutes. But I do want to talk about cochlear implants just briefly. A cochlear implant is literally a way to bypass damaged or missing hair cells in the cochlea. So it's replacing that hair cell transducer system, and it directly stimulates the cochlear nerve, the 8th auditory nerve. The nerve impulses, once they are stimulated with electroacoustic stimulation, then they are delivered to the brain just as if the cochlea was stimulated in the normal auditory pathway system. What the implant does is that it takes incoming sound through a microphone and it divides that sound into a series of frequency bands. It modifies those bands and then it delivers each frequency band to the region of the cochlea that is sensitive to that sound. You remember in your anatomy and physiology class and in your audiology class, you learned that the cochlea is arranged in a tonotopic fashion, that at the basal end of the cochlea are the high frequencies and at the apical end of the low frequencies. So the cochlear implant is then sending signals across those frequency bands. So cochlear implants are certainly an option. They were used first in this country in the mid-1980s. They were under the Food and Drug Administration's experimental protocols, and so individuals who were chosen to receive a cochlear implant, adults first, until we figured out that they were safe, and then later children, were specifically selected under a strict experimental protocol. Now, they are not under any experimental protocols. They are implants may be implanted if the physician determines that that's appropriate for the client. The general guidelines, though, still remain that cochlear implants are an option for individuals with severe to profound hearing losses, or individuals who get minimum gain from a hearing aid. Generally, that minimum gain is defined as speech recognition scores of less than 50%. Now, the protocols vary some. There are some individuals who have severe hearing loss and maybe a little bit better speech recognition scores who may be implanted. Still, for children, we typically think severe and profound. We also, for children, want to see those children at least have some brief period of hearing aid use to see if they could get benefit from therapy and intervention in hearing aids. If they have one of the diseases or disorders that are progressive, that lead to profound hearing loss quickly, we may implant them early. For example, if they have meningitis, soon, if they recover, when they recover from the severe meningitic episode and are able to undergo a surgical procedure, we might implant them very early because we don't want to lose any time. And we know that the history of that particular disorder is the severe to profound hearing loss. Typically, hearing aids work best for conductive hearing loss, for mild to severe sensory neural hearing loss, and cochlear implants are really the option for individuals with very severe to profound hearing losses. We do sometimes, with individuals with conductive hearing losses, we use bone-anchored hearing aids, the Baha system, which provides stimulation to the cochlea to bypass middle ear difficulties. Here's what a cochlear implant looks like. It's really, again, fairly simple. It has internal components and external components. So the truth is, it's not a bionic ear. There's still an external component. There's a microphone, there's a sound processor, oftentimes looks very much like a behind-the-ear hearing aid, and there's this transducer or transmitter system that transmits the signal from right here into an implanted receiver in the mastoid bone that transmits the electroacoustical signal. It goes down an electrode array and is inserted in the cochlea. So you've got these external components and these internal components. What happens is the sounds are picked up by the microphone of the cochlear implant, the external part. That signal is then coded into these electrical pulses by the speech processor. Those pulses are then sent to this coil, which is the outside part. It's then transmitted across the skin to the internal part of that transducer. That implant then sends those electrical impulses to the electrode array that's inserted into the cochlea, and then the auditory nerve, the same 8th auditory nerve, picks up those electrical pulses and sends them to the brain, and the brain recognizes those electrical signals as sound. Again, this is just a little schematic from MED-EL, which is a big manufacturer of cochlear implants in this country. Again, you may want to look at table 3.4 in your textbook. That is the candidacy requirements for cochlear implantation. These are the conservative candidacy requirements. Again, because these devices are now no longer under the FDA experimental protocol, it is a decision by the physician about which individuals he or she chooses to implant. But these are generally the candidacy requirements. Again, still relatively restrictive for children 12 to 18 months, much less restrictive for children under the age of 18, and then even less restrictive for adults who are making their own choices. We are implanting children below 12 months, but one of the issues is always the degree to which the skull can maintain the internal and external components and the rapid growth of the skull in infants. So it's not like we can implant 2-month-olds or 3-month-olds. Their skulls simply won't maintain the instrument itself. You do want to look on page 113 in your textbook for a little schematic. It's figure 3-8. It's the same kind of schematic that you looked at for hearing aids, but it looks at the schematic for a cochlear implant. Again, I always think that as an SOP, if I can understand those two schematics, one for the hearing aid and one for the cochlear implant, I've basically got the important information well in hand, and I can explain it to a family. Different devices look different. Different devices are changing. We now have shorter electrode arrays that we're using with many children hoping to retain some residual hearing in the implanted ear. So again, the benefits clearly show that children who are implanted at or about 12 months, who receive intensive early intervention and have families that are providing rich language environments, do develop auditory and expressive communication similar to their normal hearing peers, unless they have other factors. 40% of children who are deaf in this country have other disabilities. So it is not true to say if we just implanted this child at 12 months, they will have normal hearing and language skills. that is simply not true. One, there are these other disabilities that have to be considered. Two, is this a family that's going to actually use the implant? Little kids can't put their external processors on by themselves. So it takes a family who's committed to the process. They need intensive speech, language, and hearing therapy. Can the family get them to that? Can we bring that to them? So we need to be realistic about the challenges that we face. We have excellent technology, but can we get the whole system to benefit and use and implement the technology? Again, we are seeing patients with CIs who like this thing called bimodal stimulation. So they like hearing aids that give them better acoustic signal representation, particularly for music and for multiple languages. So when we think about this whole idea of bimodal stimulation, electrical stimulation to the implanted ear through a CI, and acoustic stimulation to the other ear with traditional hearing aids, again, lots of people, particularly adults, like that. They say it's a more natural sound. They can appreciate music that they remember loving before they lost their hearing. So again, it's important to think about what options are out there because there are lots of different options. Whether they're children or adults with a cochlear implant, they may benefit from hearing aid acoustic amplification in the other ear. They might benefit from 2 cochlear implants. Again, cochlear implants can improve speech understanding. They certainly don't have feedback like traditional hearing aids. Audiologists, though, have to map the speech processor. It's not a one-step process. It's a surgical implantation, and then 4 to 6 weeks later, the external processor is hooked up, and the audiologist maps the speech processor. More stimulation to this frequency band, less stimulation to this frequency band. That is a process that requires multiple trips to the audiologist, adjusting that map. So adjusting those stimulus parameters to get optimum speech recognition is this process called mapping. And again, the audiologist is looking at trying to adjust the range of the sound stimulation that a person gets. They're looking at loudness balancing, programming the speech processor so the stimulation gives the patient that sense of this was a soft sound, this is a moderately loud sound, this is a really loud sound. And if they're not balanced, the patient may experience popping or other extraneous stimulation. So there are a lot of different ways in which audiologists fix that sound. The other thing that we want to quickly introduce tonight that will be part of your communication modalities project is these things called assistive listening devices. These are other devices used with or without a hearing aid or a cochlear implant that are used to improve listening in specific situations. Classrooms that are noisy, restaurants that are noisy, movies or other public events. Because the listening environments that our patients encounter are oftentimes compromised listening environments. We are on page 120 in your textbook, where your author begins to introduce this idea of assistive listening devices, and talks about the fact that in any listening environment we are faced with ambient noise. That's noise that's present in the room even when there's no one in the room. So the HVA system, outside background noise, that's traffic noise. Reverberation, the echoes caused by the sound rebounding off of hard surfaces like walls and floors and ceilings. And many of you who've now been in a medical setting know that medical settings are notorious for having poor acoustic environments. Lots of ambient noise, lots of reverberation, and lots of other background noise. That's certainly true if you'll recall your experience in a school setting. So unfortunately, our patients are not in quiet listening environments lots of the time. So they may well need assistive listening devices in addition to their hearing aids, their cochlear implants, or their bone-anchored hearing aids. And there are lots of different kinds of assistive listening devices that are helpful in different situations. The idea is that the assistive listening device is going to enable your patient to get a more direct and clear signal from the information that they're most interested in. The teacher talking, the healthcare worker close to them who's asking questions. So they're FM systems, stands for frequency modulation systems, that essentially use radio waves to transmit a sound. There are two major kinds of FM systems. A personal FM system, which is where the speaker, many of you did this when you were in school, you wore a wireless microphone as the speaker. The speech then is frequency modulated on these radio waves and transmitted through the room to your student who was wearing a receiver. The receiver then is connected to the person's hearing aid. It may be built into the hearing aid, or it may be attached to the hearing aid using what's called an FM boot, or it may be directly interfaced to the hearing aid. The other option that is sometimes used is a sound field FM system, where the teacher or the speaker wears the microphone, but the signal is transmitted to loudspeakers that are positioned throughout the room or in different arrays, and then the sound is transmitted through essentially the loudspeaker to the individual. Auditorium classes, exactly, Nicole, exactly. Auditorium classes oftentimes do have these telecoils. They'll be what they call looped, L-O-O-P, a telecoil loop. We also see infrared systems. That's where the signal is transmitted on an infrared signal, a photo detector, and those systems are oftentimes used by people who are watching TV at home, and there are other people in the family watching TV in a skilled nursing facility, and there are other residents who don't want the TV turned up so loud. Obviously, infrared systems don't work outdoors because sunlight interferes with the infrared carrier waves. This loop system is becoming more and more popular as the simplest but most efficient technology in large open spaces. So when you're in a large open kind of space, there literally is a wire running around the circumference of the room, or if it's a big discussion table or conference table around the table, and that wire conducts electric energy from the amplifier, creates this magnetic field with the telecoil on the hearing aid. Sometimes the individual will wear what's called a neck loop, so a tiny loop around their neck. Sometimes it simply connects to the telecoil and you push the volume control or the off-on microphone switch over to T, and the signal is carried directly to the patient. So there are some of these simple amplification systems that you can use with telephones. It is a Federal Communications Commission requirement that all telephone carriers provide amplified telephone options for patients with hearing loss. They can either be placed in the phone handset, they can be clipped onto a handset and essentially amplifies the sound coming out of the telephone receiver. There are also a variety of text systems and telephone relay systems that we'll be talking about that individuals who are part of the deaf community typically use. There are hardwired systems that sometimes individuals use where they literally can connect their hearing aid into the telephone with a direct auditory interface. Hats, yes, you can. That same law, exactly, will provide some funding for AAC for clients. We are seeing much more, many more options for funding hats, assistive listening devices, and AAC devices, voice output devices, available now under those funding laws. So SOPs, I think, used to say, well, that would be wonderful, but my patient can't afford them, or that would be wonderful, but blah, blah, blah. And basically it amounted to a cost issue. Now, if we are diligent and do our homework and access those advocacy groups that help families locate the funding and access through our school systems those funds, there is funding for many, many of these kinds of devices. Hotels, for example, large hotels must provide rooms that are accessible. And we go, oh yeah, they got to have wide doors, and you got to be able to get in the bathroom in a wheelchair. That is true. But they also must be auditorily acceptable. So a person with a hearing loss who goes to the Hyatt, the Marriott, the blah, 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 can ask for an auditory accessible hotel room that must provide lots of these things. Must provide, for example, a vibrating alarm clock. Must provide the door has a light flashing. The smoke detector has to flash a light. The computer has to be accessible. The phone has to be accessible. And again, some of that is our responsibility as SOPs to be knowledgeable ourselves about these technologies, but to help our patients and their families and significant others become knowledgeable about their rights under the law and the availability of these various types of assistive technology. So thank you, Kelly, for that comment. Again, these technologies, often called HATs, sometimes the term HATs and ALDs, assistive listening devices, are used interchangeably. Technically, hearing assistive technology are all these other things other than communicating speech. So what's our role? Our role as an SOP is to advocate for appropriate and functioning amplification systems for our clients. Our role is to advocate for improved classroom acoustics for students, improved residential acoustics for our residents in any kind of extended care. Our role is to be a source of information to classroom teachers, to caregivers about acoustics, about how to monitor hearing aids and FM systems and cochlear implants. Again, because we are the face-to-face direct interactors with patients with communication disorders. And so one of the reasons I'm asking you to develop this group communication modalities project is that so you have at hand the websites to go to, examples, just examples of these different technologies, examples of materials to be used with parents and teachers or caregivers and patients and significant others. The information you collect this summer, 2017, I'll guarantee you will be outdated in 2 or 3 years, but the source that you use will likely still be there. So Cochlear Corporation, Advanced Bionics, and NetL, the big providers of CIs, I bet will keep being the big providers of CIs. Oticon, Starkey, Phonic Ear will be the big providers of hearing aids. They're huge multinational corporations. And so they'll have new technologies out there, and that's a good thing. But you'll know how to get to them. You'll know basically what's there. You will have to refresh your communication modalities project periodically, just like you have to refresh your knowledge of specific AAC devices or specific tests or specific therapy materials. Nothing is static. And that's why we have continuing education, why we require of ourselves as professionals that ongoing information refresh for the things that we learned in school. But I want you to learn what are the sources for that information and what is the evidence-based practice that says this is a helpful strategy, a helpful technology for your patients. I want you to see if you can take a deep breath and hang in there for 14 more slides, because this is probably the most important part of this course. You as an SOP, under our ASHA practice guidelines, our scope of practice, are responsible for being able to troubleshoot these devices. Again, on the basic premise that you are the person closest to your patient on a daily or weekly basis. And if acoustic accessibility, or this term that Dr. Matlock kept talking to you about called audibility, the ability to access spoken and auditory information, is critical for your patient to effectively communicate, then it's got to be audibility, acoustic accessibility without the interference of noise, reverberation, distance from the speaker, and the impaired auditory system that your patient has because of their disorder. That improvement in audibility is the goal of all of these devices. All of these amplification devices, cochlear implants, bone-anchored hearing aids, assistive listening devices, hearing assistive technologies. So we have to think about how to address those problems. One, we have to make the sound loud enough. That's really actually fairly easy to do. We simply increase the gain or the output of the amplification device so the sound is audible. And we can shape the response of these devices so that we can amplify certain frequencies more than others. So we can address this thing called the frequency response characteristics of the amplification system. And that's what audiologists do. So the problem comes that once the audiologist fits the device, the physician implants the device, we turn it over to parents, to teachers, to caregivers, to the patients themselves to somehow manage these devices, to learn how to use these devices. And whether it's hearing aids, cochlear implants, BAHAs, those devices don't operate by themselves. They have to be tested periodically to make sure they're functioning properly, that they're delivering what the technology promises to deliver, which is audibility and accessibility to sound. For young children and for geriatric patients, that really requires very close vigilance because they can't oftentimes verbally tell us what's the matter with their hearing aid, what's the matter with their CIs, what's the matter with their BAHAs. And typically young children need these frequent ear mold changes if they're in a system that has an ear mold, because their feet grow and their ears grow. So teachers and parents and caregivers have to be trained and encouraged to closely monitor the person's responsiveness to sound. If a person suddenly has a change in their responsiveness to sound, their ability to react to their name being called, their ability to respond to stimulation in speech and language therapy, that could mean that the hearing aid or the cochlear implant or the BAHA is not working. It also could mean that their hearing level has changed, that they've developed a conductive component, a middle ear pathology, that, hopefully not, but that their hearing loss has progressed, it's diminished further. And so our role is to do that monitoring. The real problem, though, is that poor functioning amplification is a long-standing problem. Research studies across many different areas of the country, both in this country, in Europe, in Australia, have repeatedly shown that about half, the number varies, but about half of children have devices on a given day that are not working. There's similar results from geriatric clients and long-term care settings. About half, again. Studies range from about 40% to about 60%, but on average, about half of these devices don't work on a given day. Now that is devastating, I think, to us who are SLPs. We're counting on those devices making a difference for our patients, our students. But if half of the time they don't work, then we have a real problem. Certainly our patients, our clients, our students have a real problem. The results of these research studies over and over again have said that those malfunctions are typically minor problems that could be corrected easily by the teacher, the parent, the CNA, the nursing staff, the SLP, not problems that require that the devices be returned to the audiologist or the manufacturer. So we have to have an aggressive amplification monitoring program, daily amplification checks, to see if we can get a higher rate of devices doing what they're supposed to in terms of giving our patients access to the auditory signal. IDEA 2004 requires that school systems monitor hearing aids, FM systems, CIs, and other devices on a daily basis and document that the devices are functioning. Now, we've talked about this before. We talked about it in the spring. That doesn't mean that you personally, as the SLP, have to go around every school and check every child's hearing aid. But the district is responsible for daily monitoring and documentation. So, we need to make sure that our district understands that, citing the IDEA, and we need to participate with an educational audiology consultant to see that we know how to check hearing aids, cochlear implants, FM systems, that teachers, that SLTs or paraprofessional, and that parents know how to do that. And then it's an individual decision in a school who's going to do that each day for each student. There are simple daily visual and auditory checks, again, that can alert us to when there is a problem and when the aid, the CI, the BAHA needs to be returned. And I put up in eLearn several different check monitoring charts for you to use. I put up in eLearn, and we're going to go over how to set up a little check, a little hearing aid check system. I gave you the Oticon website that also puts that information out and gives you nice screenshots of how to do this check. What you need to do this with is some sort of little case. I mean, I frequently use a little zipper pencil case. I've seen people use the kind of clear plastic case that we now take into professional supporting events to get through the screening monitors. But some sort of little case that has what is called a hearing aid stethoscope, a battery tester, extra batteries for the clients that you serve, brought to you by the family, a wire, a brush loop, instructions, some sort of little picture of the hearing aid with the parts labeled so you can train other people, and information on how to contact the audiologist if the hearing aid has to be returned. I put up in eLearn a little parent notification letter that we oftentimes send home with parents of school children saying, your child's hearing aid or cochlear implant or FM system was checked today, and here's the problem. Please contact blah, blah, blah. We can modify that for our residents in long-term care and provide that to families. But here are the specific steps in how to do that. You have to first check the battery. Remember, that's most often the problem. So you open the battery door for the hearing aid. You remove the battery and you put the battery in a little battery tester. So you check to see if there is voltage in the battery. Then if the indicator says that the battery's dead or dying, you put in a new battery. You replace the battery in the hearing aid. Remember, batteries only fit in these hearing aids one way. And there's usually a little plus on the case as well as a plus on the battery, so you make sure that the battery is inserted properly. And if you can't get the battery door closed, that's because the battery's in backwards or is in incorrectly. So you want to make sure that you are checking that. You want to look in your textbook on page 663 for a little more description of this checking hearing aids. Kind of what's this system like. So you check the battery. Then you listen to the hearing aid. And the way you listen to the hearing aid is you use a little stethoscope or stethoset. That little stethoscope or stethoset enables you to use your good ears to listen to the hearing aid and to determine, is this hearing aid providing appropriate amplification? So you're listening for, does the hearing aid amplify the sound, or is the sound cutting in and out? Is it crackling? Is there no sound? Is it amplifying some sounds but not others? Is it distorted? So you are using the fact that you have normal hearing and you can make a judgment on, is this hearing aid providing the appropriate sound for my client. Audiologists typically fit hearing aids so that the volume of the hearing aid is about half on. You don't want the hearing aid turned up to maximum on, because that tends to lead to distortion. So it's typically half on. Now the numbers, some hearing aids have a volume control where they're numbers, others it's just a rotation of the dial. But you're listening to the hearing aid using your good ears. And what do you say? You use something called the Lean 6 sound test. These 6 sounds, originally developed by a man named Daniel Lean in Montreal, cover the speech range. I put up in eLearn a description of the 6 sounds to help you recognize what they do. So the sound is about 250 to 300 hertz. It's that nasal murmur. The sound is that sound right at 1,000 hertz. You've got ooh and e. The difference in ooh and e is the seconds formant, and if the child or the adult or you can't hear E clearly, then something is happening to that second formant, that higher frequency. And sh are also high frequency sounds. So when a person can't hear sh, it's about 2,000. When you are listening and the sound, the S sound, is distorted, you know that's about 4,000 hertz. So the reason for choosing these sounds is that they cover the frequency range from 250 hertz to 4,000 hertz. You should be able to hear them clearly through the hearing aid when you say them. You also shake or squeeze the hearing aid to see if the hearing aid is cutting off and on, in or out. You look for cracks in the casing of the hearing aid, or in the ear mold, or in the tubing. If the hearing aid does do that whistling, that feedback, you want to look and see if the ear mold is broken or cracked. You want to insert the ear mold into your patient's ear, the child or the adult, to make sure that there are not any gaps around the ear mold where that sound is feeding back. When you check the ear mold, you want to be looking to see that there's no wax buildup in the canal of the mold. If there is a wax buildup, you want to insert a wax loop, a little loop of wire that removes the wax. That little loop can then take the wax away from the ear mold. You wipe off the loop, you put it back in, and keep doing it until you clean the ear mold. If there's any foreign material, dust, dirt on the ear mold, you can wash an ear mold in warm, soapy water. Do not ever use alcohol or wipes with alcohol in them on the ear mold or the hearing aid case, because it will dry it out. So only use warm soapy water or something called audio wipes, which are especially designed wipes, not with alcohol in them. If the ear mold or the hearing aid case looks dirty after you cleaned it, then you obviously send a note home to the parents or to the family of a senior and ask them to see if they can correct the problem or contact the audiologist. So our role as SLPs in amplification is to advocate for appropriate and functioning amplification system for our clients, to advocate for improved classroom acoustics for students and residents in extended care, and to be a source of information for classroom teachers and caregivers, ray acoustics, and monitoring of hearing aids and FM systems and cochlear implants. So again, we have to be basically knowledgeable about these devices and how they function. We can assist our audiology colleagues by encouraging consistent use of devices. We can set a treatment goal that the patient will consistently use the device, that they will gradually increase the time that they wear their device in first quiet, easy listening situations, and then gradually in more challenging listening situations, until they're using their device consistently throughout their day. Again, we have to monitor and document the performance of all of these devices on a daily basis, or assign and train someone else to do that. And most importantly, we have to educate parents and teachers and caregivers on how to monitor these devices. I do want to encourage you to use those resources that I put up in eLearn. If your school doesn't already have a hearing aid test kit, they are available on the commercial market for somewhere, usually about $35 or $40. They come with a hearing aid battery tester, a listening stethoscope or stethoset, a little wire loop and a little brush to clean, and typically come with a little picture of how to do this process. Again, if you look at the Oticon handout that I provided in eLearn, that's another example, again, with nice pictures that show you how to do that. I put up the educational audiology forms to be used in school systems to track the process and to send notes home for parents if the hearing aid or the CI or the FM system needs to be returned. But I think our issue is that we have to make sure that the places that we work have a system and that we are providing that information. We use this Lean 6-sound test to check the hearing aid using the CI or the Baha using our good ears. We assume that you have normal hearing and that if you say these 6 sounds, which corresponds to 250, which corresponds its first formant to 500 hertz, which corresponds to 1,000 hertz, which corresponds to about 2,000 hertz, which corresponds to about 4,000 hertz, and E, the first formant, is down there at 500 hertz, just like OO, but the second formant of E is up near 1,000 hertz. So if the hearing aid is not amplifying OO and E well, you know you've got a problem up there in the higher frequencies. And then we are going to use this 6-sound test next week when we talk about auditory training. We're going to use the 6-sound test with the amplification device, the CI, the cochlear implant, the Baha, the FM system, on our patient. And we're going to see, can the patient hear these sounds? And we're going to talk about how to do that. It becomes then the functional listening test for your patient every day. But the first way that you use it is to see if you can hear through the amplification device itself. There is a little app. It's on the iPad, not on the iPhone. It's called Auditory Verbal. So if you just type in Auditory Verbal into your search for apps, that has those little pictures, it actually says the sounds. People can practice. I put up in eLearn just a set of little pictures that SLPs oftentimes print down to have to do this 6-sound test with their patients, their younger patients. And we'll talk about that next week in more detail when we move on to Chapter 4. It is definitely time for us to go. I will stay on the line to entertain any questions or comments or personal issues that you have. I want to thank you for your attention I will turn off the recorder so that we can have some private conversations if we need to. Thank you very much. I hope that you have sort of an idea about amplification in hearing aids. Good night, everyone. I'm going to stay here on the line again if some of you have questions that you need to ask or answer. I am going to turn off the recording.